heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community.
Hello and good morning. Good morning and welcome to our latest CAHN session delivered by CAHN. CAHN, as you know, is the Caribbean and African Health Network and is dedicated to bridging the gap in healthcare access inequality between the Black and Afro-Caribbean group as a unit and the general population on the other side. Today, we're going to be talking about inflammatory bowel disease. And this talk is going to be delivered by Dr. Marwa Jama. Marwa is a specialist registrar in general surgery working in Yorkshire, and she's very keen to share her knowledge and experience with the rest of us. Also, normally it's just one speaker, but today we have two. CAHN has been heavily involved in some research work with the Crohn's and Colitis Society of UK, and there'll be a representative from Crohn's and Colitis UK to share some of the information with us, and also a little bit from CAHN themselves to go into some detail about what the work entailed. So we're going to have quite a few speakers today. Yes, whilst we're on the talk, it would be very helpful if you could use the chat feature to tell us where you're joining us from and to communicate with us generally. If you have any questions, just put them on the chat and we shall take questions later towards the end of the chat. Without much further ado, I think I will pass on to Marwa. And Marwa, the floor is yours now. Thank you.
Thank you very much, and thank you for the introduction. I will attempt to share my slides. So I hope you can all see them now. So good morning, everyone. My name is Marwa. I'm a specialty trainee in general surgery in the Yorkshire Deanery, like Dr. Sapong has kindly said. And I'll be talking to you about inflammatory bowel disease today. So I've been asked to do this presentation because we as general surgeons look after this disease or this condition, I should say, along with gastroenterologists who do the main bulk of the medical treatment. So before I get started, I would like to credit Ms. Tabitha Ghana as well with the work that has been done. She's a consultant colorectal surgeon in Bradford and has kindly assisted with the design of these slides. So when we get started, I would like to tell you a story because I don't think many of you might be familiar with IBD. So meet this lovely man. This is Mr. M. Let's call him Mr. Morrison. He's a 64-year-old male living in Birmingham. He's of Jamaican descent. And in the last few years, maybe the last 7 or 8 years, has had 2 or 3 episodes of bloody diarrhea for a few days, which he kind of ignored, and it settled down on its own after a few days to weeks with some abdominal pain and hasn't done much about. He tried some other things. He credited to some maybe being on holiday and having some infections. He once went on a bit of a course for antibiotics. He sought some alternative medical treatments, and didn't think much of it. Then over the last few months, maybe a year or so, he starts noticing he's losing a bit of weight. He thinks it's because he's retired and started doing more movement rather than his normal office job, and doesn't again think much of it. And then he has another episode of bleeding, which is slightly more fresh and more profound than his usual bloody diarrhea was. So after consulting with his wife, often this age group gets sent in by their partners, his wife asks him to attend his GP. So the GP does find some piles, and Mr. Morrison thinks, that explains my bleeding. But the GP is not happy to see his recorded weight loss and sends him onwards to the hospital for what's called a 2-week wait referral, which is to investigate the possibility of a cancer. So he gets sent to a general surgery in hospital, goes through the tests of a CT scanner and an endoscopy, which is the routine. And unfortunately, Mr. Morrison is diagnosed with a bowel cancer of his large intestine, but also on a background of ulcerative colitis. And this explains a lot about how Mr. M's life has been in the last decade. So that brings us to what is this? So Mr. M has got ulcerative colitis, and ulcerative colitis is one of the two most common inflammatory bowel diseases, of which the other one is called Crohn's disease. So inflammatory bowel diseases are a group of diseases or a group of conditions that are mostly immune mediated. So they're kind of autoimmune, where the own body has an immune response to the bowel with a complex and not fully known mechanism behind it. But it's a disease that's on the rise. And I think today what we need to talk about is how it affects people in our communities. So in European societies or in the Western world, the incidence has been rising for a long time and then plateaued for about the last decade or so. But it still has a very high incidence rate, which means it's very common. So in the UK, 1 in every 123 people lives with an inflammatory bowel disease of some sort. And I know that doesn't sound like much when you think of it, but try to think of this on this way. If you go on holiday, an average airplane means that there's already 2 people on there with a Crohn's or a colitis. If you go to a medium-sized supermarket, one of the people in there will have Crohn's or colitis. If you go to a primary school, 2 or 3 children will, or actually 3 or 4 children will end up having IBD at some point in their life. So if you think about it that way, and you probably know a lot more than 123 people, someone in your environment has or will develop IBD at some point. So IBD, so inflammatory bowel disease, which I'll be calling IBD from now on, if you don't mind, has got a complex pattern to it. There is some genetic component, people who've got a family member, so children of people who've got IBD or people who've got multiple people in their family are more predisposed to having Crohn's or colitis. But it doesn't necessarily mean that if no one of your parents has got Crohn's or colitis, that you are free of it or never going to get it. It doesn't work that way. Historically, used to get associated with the disease of the rich, as in a disease of the developed world, where food and the lifestyle and everything else was being related to it, and therefore not a problem for Africa and other developing areas. But this is not true. These countries are seeing an incredible rise. It might also be because they are more industrializing and starting to develop similarities in diet to these countries. The low sun exposure that has sometimes been offered as a possible mechanism behind it, again, with industrialization of the west of the sub-Saharan Africa has probably got an incidence rise in it. So that idea of, oh, it's a disease of rich countries, or it's a disease of the Caucasian race, is completely outdated. And one of the country areas that are seeing the highest rises are actually sub-Saharan Africa. So how does this present? What would your symptoms be? So this differs for ulcerative colitis and Crohn's because they're two very different conditions. So I'll try to go into both of them. So I'll start with ulcerative colitis, which is the condition that Mr. Morrison had. So ulcerative colitis often gets diagnosed at a young age. Most people will get diagnosed in their early adolescence, early adulthood, so around their 20s and 30s. But there is a second peak at older age. There is a similar incidence or similar risk for male and female. It doesn't matter if you're man or woman. But in the older presentation groups, so later on in life, it tends to be slightly more men than women. And this often presents with bloody diarrhea, so diarrhea mixed in with streaks of blood and abdominal pains. And your symptoms kind of depend on where ulcerative colitis is affecting you. So the colon is the last part of what we call the gastrointestinal tract. So when your food travels down, it travels from your mouth into your gullet, your stomach, travels to meters of small intestine, and then lands in your large intestine, which is called the colon. And then your colon ends in your rectum and anus, and that's then where the stool evacuates from the body. So the colon, the last bit of your intestine, is the bit that's affected with ulcerative colitis. And ulcerative colitis tends to start on the left side and mostly in the rectum, so in the end, and then creeps up. And it doesn't do that for everyone. In some people, it just always stays limited to one portion, but it can creep up the whole colon and it can affect the whole colon. And depending on that, the symptoms might just be losing blood, having diarrhea, but then if it gets affects more and more of the bowel, you can get lots of abdominal pain. And if later on, you can also get complications from this, which I'll go into at a later stage. Other symptoms obviously will be fatigue, secondary mostly to the anemia, because if you're losing that much blood, obviously you'll develop an anemia at some point if you don't seek any treatment or help. People will struggle to maintain their weight and they'll lose weight because of having constant diarrhea and all the nutritional effects of this. A late stage complication of this can be things like fevers, because if you've got severe inflammation of the bowel or even a secondary perforation, then you can develop fevers with this. Or they might develop symptoms from the conditions that you can get along with Crohn's and colitis, because obviously, and I'll go into this again later, unfortunately, people with Crohn's and colitis are also more prone to have other autoimmune mediated conditions along with their IBD. Crohn's tends to affect, or has the possibility to affect, a lot more of the so-called gastrointestinal tract. So where ulcerative colitis limits itself to the colon and to the large intestine, so the colon and the rectum, the Crohn's disease can literally affect someone from mouth to anus and everywhere in between. It doesn't mean it's incredibly rare to be affected in all these areas, but it can have different patterns for different people and affect them in multiple areas in one go. So your symptoms can depend on the location. A common preference point for Crohn's, especially to begin with, so how people present, is somewhere called terminal ileum. That's a very technical term, but it just means it's the small intestine, just where it becomes the large intestine. And that's the point of our body that sits on the right. And often these people will present with right-sided abdominal pain, again, diarrhea, and a bit more profound than in the ulcerative colitis patients. The diarrhea can be slightly bloody, but that's rare because obviously blood gets digested. But because there is blood in it that you can't see, people can still develop an anemia. These people, unfortunately, and again, there's some evidence that this is more the case for Black people when looking at studies from the US, can eventually present as an emergency. So they might have had a background of this kind of abdominal pain, diarrhea, right-sided pain for months or years, which they kind of not gotten a diagnosis for or not gotten to the bottom end of, and then they present with either an obstruction of that bit of the bowel or a perforation of that bit of the bowel as an emergency setting. You can also get Crohn's colitis, so that's where it affects the large intestine, and then it's exactly the same as the colitis of the ulcerative one. And another common thing that Crohn's does, and there is some evidence that, again, Black people are more predominant to presenting with this area of Crohn's disease, is perianal disease. So the anus is the last few centimeters of our intestinal tract. And what they can develop is a so-called anal fistula. The fistulas can cause abscesses. So on this image, and I'm not sure if my pointer can be seen, but if you look at it, there's a main tube in the middle that's got some pink halfway through, and then you can see a little line here, and that line is not supposed to exist, and that's an open tube, and that's called a fistula. So it's an abnormal connection between the buttock skin, because this is the skin of the buttock, and the anus itself. So obviously this is a dirty area for everyone, because obviously it's contaminated with stool, and this can cause so-called abscesses. And I think I might have a picture of that later again. So perianal disease is very common. Crohn's patients, up to half of them can develop perianal disease at some point within their condition and have complicated abscesses because of this. And like I said, there is some studies and pointers that this is a problem that's more prominent in the Black population with IBD. So, how do you diagnose this? So again, the diagnosis and the set of symptoms will depend very much on location, but very often it will be a combination of people having unexplained abdominal pains, weight loss, fatigue, anemia, all kinds of vague, actually relatively vague symptoms in young people, which makes it hard to recognize. And then in a non-acute setting, so if they haven't developed any acute illness from it and are just attending their GP will often do what's called a calprotectin. So it's a stool test that can tell us if there's inflammation going on. Often bloods will give you some pointer if someone young is having an anemia, or someone old, to be honest. Having an anemia can be a pointer. And the final diagnosis is made on endoscopy with biopsies. So endoscopy is a camera test, and I'll show you how that works in a minute. And scans are incredibly helpful. So these can be CT scans of the abdomen or MRIs of the abdomen or the pelvis to kind of help us a bit more with what kind of disease there is. But these are case specific, obviously. So what is endoscopy? And I think I've used this image before. So endoscopy is just a camera going into the gastrointestinal tract, and we can do what's called a gastroscopy, which is from the gullet into the stomach, or we can do what's called a colonoscopy. There are different forms of this, but I won't go into that today, which basically means that the patient goes under a slight sedation with some painkillers, and then has a camera inserted up the back passage, which allows a direct view of the inner tubing and the inner lining of the bowel, and allows you to take some biopsies to hopefully make a final diagnosis of colitis or Crohn's. So the treatment again depends on what kind of symptoms and what areas affected and at what stage. So going into that would mean having to do a few lectures, and it's obviously not something you would want to do on a Saturday morning. But the mainstay of the treatment is medical. So a lot of patients manage to get medical treatment, which is because with anti-inflammation modulating drugs, which are called 5-ASA, and immunosuppressants and immunomodulators, which have got lots of different forms and tend to end on MAPs and things. And I'm sure Sophie can tell you a bit more on that later on. And surgery. Like I said, this is an area of conditions that get shared between gastroenterologists, which are medical doctors, and surgeons. So sometimes, unfortunately, surgery is needed for these patients, either in the acute setting or even as a planned elective procedure. So, for example, the perianal disease with the fistulas can cause abscesses, and these abscesses need to be drained. Sometimes you can't, when you go on medical management, these abscesses or the fistulas, sorry, tend to keep reoccurring, tend to get more complex, can develop more abscesses. And sometimes that means that just to give the areas some rest, we end up giving the patient a stoma higher up so they don't have to use the anus anymore. When the colitis becomes severe, in some cases, you have to do an emergency or an elective procedure to take out all of the large intestine, and then you can make an end stoma. So there are lots of different ones that we can do. And some examples are here. So an ulcerative colitis, if it's failing medical treatment, then the whole colon eventually has to come out, which means that you're left with the terminal ileum. And then there's two options. You can make a stoma, so an end stoma. So stoma is this here, where the intestine is brought out to the skin, and the patient wears what we call a bag, so a stoma bag, where the fecal material just accumulates in a bag, and the patient learns how to manage this bag and change it. Or you can end up with something we call a J pouch, which is then where a bit of the small bowel gets made into a new rectum and joints up. And for some people, that's something that then makes them have stools from the normal route, as we would say, although it comes with lots of downsides as well, and it's not suitable for everyone. So that's the intestinal pouch I mentioned. So that's a bit of the small bowel rather than connecting it to the skin. It gets made into a bigger pouch to have some reservoir, and then it becomes a new rectum. And then the patient just opens their bowel from the normal route, or from the anus, I should say. But again, not suitable for everyone. And obviously, it will still not be like it was before. These patients tend to have to go to the toilet multiple, up to 10 times a day to evacuate their bowel, because the reservoir doesn't work the same, and the bowel content obviously is much thinner. This is the perianal fistulas we talked about earlier. So sometimes for the fistulas, to let the area drain and clean it, we put something in called a ceton, so a thread. So there are multiple types of surgeries we do at the bottom end. And often if the perianal disease keeps reoccurring, can't get managed with the biologicals and all the medical treatment, and the patient is incredibly symptomatic, you sometimes have no other option than diverting from the area to give it a rest. And then the patient ends up with what we call a loop colostomy. So they get a stoma bag on the large intestine just before it becomes the rectum. And that allows you to then calm the area down and continue treatment, and then hopefully at some stage reconnect things back. So what does living with IBD mean? So IBD, traditionally, especially before a lot of these new medications and treatments came out, did affect the life expectancy of people. Because you can imagine that developing complications from this and having major surgeries or major complications can cost you your life. And that life expectancy gap is closing. And that's also because the cancer risk is reducing, because a lot of these patients, because of the chronic inflammation and the chronic damage to their bowel, would eventually develop cancers of the intestinal tract. And because of better screening options and better awareness of this, the risk of dying from an eventual spread cancer is also reducing. But the cancer risk is still higher than the general population. Patients with IBD are also more at risk of having other conditions that are immune mediated. So they can get things like eye conditions such as uveitis, which is a chronic inflammation of the eye. They can get something called ankylosing spondylitis, which is a inflammation of the joints, especially usually in the spine and the back. They can get other skin conditions, liver conditions, which are all immune mediated. And these conditions obviously also come with a lot of symptoms, their own issues, and their own effects on the patient's life and life expectancy. Other questions that might get commonly asked for women is things like fertility and pregnancy, especially because this is a condition that gets diagnosed in young people and affects them for a large part of their adult life where these kind of issues would come up. So there's no direct effect on fertility, but there is some indirect effect on fertility. Pelvic surgery, so having had pelvic surgery because of your IBD can cause some scarring in that area, and therefore women sometimes are more at risk of having things like an ectopic pregnancy or having more difficulty conceiving. Flare, so being in an active flare, increases the risk of pregnancy and increases the risk of loss of a pregnancy. And obviously, some of these medication that people are on might not always be suitable for them to be on while pregnant or lactating. And another issue can be that patients with IBD obviously do sometimes have things like stomas or perianal disease or perineal disease that might affect their confidence or ability to maintain relations as they would normally. So like I just mentioned, IBD patients might have stomas, and I think stomas are something that we, within our, or well, my personal experience of our own communities are maybe not as familiar with. But stomas are incredibly common. Lots of people live with stomas, and you might know a few people that are living with stomas that you actually don't know have got stomas. And you can live an incredibly full and active life. And actually, while a lot of people are afraid of having a stoma, most people who end up getting a stoma report even a better quality of life than they had before. So you can do lots of things with a stoma. You can have a stoma bag, you can still go swimming, you can still be an athlete. There are some athletes that do triathlons, such as this lady. And you can do your office job without anyone knowing, and you can do lots of things more. This person is Dwight Eisenhower, an American president in the 60s, and during his presidency, he actually developed Crohn's and ended up with a stoma. So now comes the bit that's important for us, IBD and being Black. So there is limited research on how Black populations in the Western Hemisphere are affected by IBD. We know that Sub-Saharan Africa is seeing more and more IBD, but there is also a suggestion that the gap between second and third generation diaspora Black people living in Western countries and their Caucasian counterparts is closing, meaning that you are more and more at risk of developing an IBD. So the US-based research kind of suggests that there is a later presentation or later diagnosis of IBD in this patient population, meaning that they get recognized at a more advanced stage. Unfortunately, they tend to experience more hospitalizations, surgeries, and complications. This could be due to the fact that they present at a later stage, but it might also be that the care they receive afterwards doesn't fully suit how their disease is presenting and behaving. They often tend to be more highly concerned about their condition, and it's more associated with distress about the condition, and they report a lower quality of life, which can also be that there is a gap between what healthcare providers are providing for this population or what this population needs. So what can we do as a community? I think what's important is initiatives such as this, which CAHN has been doing, and I thank you kindly for the invite. It's to talk about it and be aware of it, and be aware that these symptoms are things that you need to present to a doctor with, and that just because you are young and fit, that it doesn't mean that you can't have anything serious. I think we also need to talk amongst ourselves, amongst our neighbors and our friends and family about these conditions, and be more proactive in seeking out not only help, because it's not just a case of seeking out help, but also advocating for yourself when you feel that you are not getting the help that you need, or that you are not getting the investigations that you need. But I think more importantly than all, it's maybe what you think we need, because obviously as a medic, I've got some ideas, and I'm also part of a community. but I don't have all the answers or any of the awareness or that you might have. And I think this is an introduction then to my colleague who will be presenting on how we can bridge this gap, hopefully. So over to you.
Thank you, Dr. Marwa. That was really interesting. And as you say, it leads in nicely to what I'm here to talk about today. I will just bring up my slides. And hopefully everybody can see that. So good morning, everyone. It's great to be here today. My name is Dr. Sophie Titcombe, and I'm from the charity Crohn's and Colitis UK. And I'm here today to talk about the information and support for Black, African and Caribbean communities that we have recently been producing with the help of CAHN. So before I talk a bit about the information and support that we can provide, I'll just tell you a bit about the charity. So Crohn's and Colitis UK are the UK's leading charity for Crohn's and colitis. And as Dr. Marwa has said, they are two of the most common forms of inflammatory bowel disease. As a charity, we aim to bring together people affected by Crohn's and colitis and support and empower people to live the best life that they can. And we do this through lots of different ways. So we run campaigns to raise awareness, we lobby people in power, we fund research into inflammatory bowel disease, and we also provide information and support. And it's really important to us as a charity to be the go-to place for everybody affected by Crohn's and colitis. And actually, when we looked into that a little bit further, when we looked at who was accessing our information and who our information felt relevant to, it seemed that perhaps there were some groups that were underrepresented, including Black people living with Crohn's or colitis. And that was something we really wanted to change. And so we worked together with CAHN to create some information which is bespoke and specific to Black people living with IBD. It was really important for us as a charity to listen to people affected by these conditions, to understand what they wanted to know about how to live well with Crohn's or colitis, and where perhaps they're struggling to currently get information. And so we did this through a few ways. So we started off by putting out a survey. So I think we had about 90 people respond to this survey, all of whom were Black, either living with Crohn's or colitis, or they were friends, family, or healthcare professionals with experience of Crohn's or colitis. We then invited people from the survey to join a focus group where we were able to dig in a bit more to understand what people wanted to see. And that was really helpful in giving us an idea of kind of the information that we needed to be producing. And from that, we were able to create a first draft of information, and we were then able to send this draft to a lived experience panel. So we've had about 9 people living with Crohn's or colitis, and they were able to feedback on what they thought could be improved. And we also sent it to some of our Black IBD nurses who we work with as a charity. And from all of this, we learned a few things. So we learned what people wanted was both integrated and bespoke information. So what I mean by this is people were really keen for there to be something specific for Black communities, but they didn't want to feel like it was completely separate. So they also wanted our general information to be relevant to Black people living with Crohn's or colitis. There was a big appetite to feature people who were Black and living with Crohn's or colitis, and also to feature healthcare professionals. We know that healthcare professionals are such a trusted source of information, and I think that reflects in that need to have healthcare professional involvement in our information. And we also learned that people wanted to know how Crohn's and colitis affected Black communities, and we're looking for specific information on food, mental health, and empowerment. And that's quite interesting because in terms of information on food, mental health, and empowerment, these are things we hear a lot from all the communities that we work with as a charity. But we also learned from the survey and the focus groups that there were some specific challenges that Black people were facing. And this included fighting stigma and isolation, explaining symptoms to family and friends, particularly in the context of perhaps bowels, Crohn's, colitis, going to the toilet not being something people felt particularly comfortable talking about. Also, there was a challenge in finding support groups that felt relevant to people, issues around bias and racism, particularly in healthcare settings, and similarly, healthcare professionals not understanding their needs. And finally, also some challenges around accessing appointments. So what did we do with all of those insights? Well, we tried to produce some information to help bridge that gap. So we did two main things. So on the left-hand side, this is some of our pre-existing information. So as a charity, as I said, we provide lots of support and information. And what we did is we looked at that information and we looked at making sure that actually it was relevant to Black communities. And we made some changes to improve that. So as Dr. Marwa mentioned, there is some evidence to suggest that Black people might be more likely to have perianal disease, so disease around the bottom. And so we made sure that we spoke about that in our Crohn's disease booklet. We also made sure that we were describing some of the skin conditions that can be related to Crohn's or colitis, talking about how that might look on Black skin, not just on white skin or fairer skin tones. We also looked at providing examples of different foods and what food groups they were under to help people with Crohn's or colitis understand what food groups are important for a healthy, balanced diet, because we know that food can be something that people living with IBD can struggle with. And finally, we looked at providing some more information on vitamin D. So people with Crohn's or colitis, because of some of the medications they take, can be at risk of getting weaker bones called osteoporosis. One of the ways you can protect against this is through vitamin D supplementation. But actually the advice for people with darker skin tones is different. And so we wanted to make sure that we included that too. And then the second thing we did, which is what I'll be focusing mostly on today, is we produced a bespoke information resource called Black Communities and Health Inequalities. And this resource really focused on those specific challenges that our survey respondents and focus group attendees told us about. So thinking about how you can advocate for yourself, thinking about what to do if you experience any racism or discrimination, and generally how you can make the most out of your appointments and live well with Crohn's or colitis. So our Black Communities and Health Inequalities resource exists on our website as a web page, and you can also download it as a PDF. So on the left-hand side here is a screenshot that looks at the 7 key sections that is included within the resource. The first one is key facts. So this just provides an overview of the resource. And then the second section is health inequalities in Crohn's and colitis. So here we define what we mean by health inequalities. So those differences in the health of people that can be due to unfair and avoidable reasons. And we focus on who might be more likely to experience those inequalities in Crohn's or colitis, of which Black communities are one group. We then look at some of the specific challenges that Black people living with Crohn's or colitis might face in our Black communities and Crohn's or colitis section. So we look at the entire patient journey. So we start off looking at diagnosis. As Dr. Marwa's mentioned, there's some evidence that suggests that Black communities might be diagnosed at a later stage. We also look at finding the right medicine, needing surgery, and also communicating with healthcare professionals. Our section on accessing healthcare moves on a little bit from that to look at those practical tips. So if you need help getting transport to your appointment, what's available? If English isn't your first language or you don't feel confident talking about your health in English, how can you go about getting a translator for your appointment? So some of those practical tips to help bridge any gaps. The next section is speaking up and self-advocacy. So here we look at how you can talk about Crohn's or colitis with lots of different people. We have a section on talking about Crohn's and colitis with friends and family. And here we have a nice video from one of our supporters, Femi, talking about how he's learnt to talk about his Crohn's with his friends. We also look at talking about Crohn's or colitis at work. Crohn's and colitis really affect all areas of life. And so obviously if you're struggling with your symptoms, that can be particularly difficult in the workplace. And finally, within the speaking up and self-advocacy section, we look at how to make the most of your healthcare appointments. So key questions to ask: how you can get a second opinion, what to do if your doctor or nurse or healthcare professional isn't listening to you. We then have tips for looking after yourself, and here we look at mental health support. That was one thing that people felt was really important and they wanted more information on. And we also have some top tips from our IBD nurses, Bridget and Aldia, who we worked with in this resource. And finally, we have a section on other organisations. So here we provide links to other support groups that might be useful for Black people living with Crohn's or colitis. Again, as Dr. Marwa said, it's really important to kind of talk about these things. And for us, we're really keen to listen. And so anybody who wants to go and look at the resource, we'd love to hear your feedback on it. And so there's two ways that you can give feedback. So the first is when you're on the web page after about a minute, you'll have a purple box pop up asking, did you find this information helpful? And you can click through the questions there. And the second way to provide feedback is if you scroll right to the bottom of the page and there's a green banner which says help us improve our information. And please do let us know what you think is good, what's bad, what could be changed, and what better support we might be able to provide. And then the final thing from me this morning is just letting you know, for anybody on the call who is living with Crohn's or colitis or knows somebody who is, just to let you know about other support that we can provide as a charity. As I said, we have lots of information on our website. So we've got the bespoke resource, which I've just told you about, but we have a huge amount of other information, everything from understanding your symptoms, to relationships, to employment. And that can all be found underneath the info and support tab. We also have support emails for people who've been recently diagnosed, so you can get a weekly email for 8 weeks, helping you learn about your condition and how to navigate life with it. We have a helpline service. This is open Monday to Friday, 9 till 5, apart from bank holidays. You can either call our helpline, live chat or email, and they can help provide support and information and a listening ear. But just to let you know, they're not medically trained, so we can't provide kind of the support you'd get from your healthcare team. We also have local networks across the country, so about 47 local networks. They are run by volunteers and do a variety of things, from providing educational talks to providing social meetups. We also have virtual social events where you can log on, join an online call not dissimilar to this, and you can chat to other people affected by the conditions. We have our Facebook forum, again, to help you connect with other people, ask questions, and talk to other people within the community. And finally, if you want to become a member of the charity, that gives you access to a Can't Wait card, a radar key, and also our monthly magazine. And that's everything from me. And I think now I'm going to pass over to Miriam.
Thank you. Thank you so much, Dr. Marwa and Dr. Sophie. You've covered for that information. And it was really, really packed. I think we need to have more of these sessions to raise awareness of Crohn's and colitis in our community. I mean, it was a pleasure working with Dr. Sophie and the rest of the team in Crohn's and colitis UK on this project to co-create the culturally sensitive and, I would say, inclusive information resource we now have on the website. From the community perspective, those who participated in the focus group discussions, the readers panels from the community, they were very, very honest and intentional in sharing their experiences. And I would say, those experiences that are often underrepresented, and, the barriers they face navigating their condition, from delayed diagnosis and very limited awareness of what they're going through, to culturally inappropriate care and stigma in the community. So all of these personal insights were from individuals were very, very valuable in shaping the resource that we now have on the website that speaks authentically to the needs, the values, the lived realities of Black people that are living with Crohn's and colitis. So that includes the language that's used. You could see the imagery and the content of the resource as well. All of this would help to enhance trust and, make it usable for Black patients. So I would say for us at CAHN, this work was, is deeply rooted in what we stand for to tackle the cultural and the structural and systemic barriers that impact our health and well-being as Black people. So by placing lived experience at the center of co-production, it was so thoughtful. And this project really, challenged the status quo, if you would put it like that, challenge status quo of patient information design. So we are pushing out for representation, we are pushing out for cultural humility, and we're in for it. And so this resource for us is more than a booklet or a leaflet, it's a step towards breaking down barriers, breaking down health inequalities. And we see how strategic engagements with organizations like the CAHN UK, like the health professionals, we can see how this collaboration with the community members can bring actionable change. At least we can see that this is on the website and is accessible for all. So thank you so much, Crohn's and Colitis UK, and we hope to collaborate more. So over to you, Dr. Michael.
So you're on mute.
Right. This has been simply brilliant. And I have to, I think a lot has been said. And a lot of the questions that I kept asking, kept noting down as we went along, kept getting answered. So congratulations to everyone. I'd like to congratulate CAHN for this work to raise awareness on IBD, and perhaps this should serve as a template to be replicated in other areas too. Just a minute. And perhaps this should serve as a template to be replicated in other areas too. Yes, and especially, I would like to also congratulate CNC UK for the comprehensive nature of the work that they've done in highlighting inequalities in the care of Crohn's and IBD. Now, we have a few questions. These are for you, Marwa. I think you may have covered some of these already, but the first question is, do these examinations give the exact diagnosis? I'm not sure where that is coming from, but I suppose it's asking about the specificity of investigations towards the diagnosis of IBD. So how safe and how sure are your investigations towards diagnosis?
So nothing is ever 100%, but most patients on a combination of having fecal calprotectin tests, scans, endoscopy, and biopsy will end up getting their diagnosis. Obviously, the difficulty comes if you don't think it's Crohn's or colitis but something else, and these other conditions can often be harder to diagnose. But yes, most IBD patients on a combination of an endoscopy and biopsy would get diagnosed.
Would get diagnosed. Thank you very much. Now, the second question, and this relates to diet. In terms of diet and perhaps lifestyle too, are there any specific or African Caribbean foods that commonly trigger flare-ups in IBD?
So To be really honest, I wouldn't know which ingredients exactly could flare up for each individual because things are different for each person. If you're talking about rather flares about the development of the condition, the westernizing of the diet has been suggested as a potential mechanism of developing IBD, but it's not proven. And if you look at the literature, different literature will say different things. So I think diet in IBD is still a hard area to comment on. I don't know if Dr. Sophie's got anything else she would want to say on this.
Yeah, I think to echo that, we know it's really frustrating because people often want to know this, but as you say, the evidence just isn't there really. It can be different for different people. Um, One of the things that we found, some people find spicier foods can be a bit difficult for them, but other people find that that doesn't make a difference. So yeah, unfortunately, as Dr. Marwa says, we can't really give any specific advice. The thing that we tend to say is kind of a balanced diet is the best thing that you can do.
Okay. Would you go as far as saying, for example, that fiber is important? Would you go as far as saying that greens, fruits, and vegetables are important, or would you still stick to your balanced diet position?
So fiber is important anyway because in part of a balanced diet, and obviously also bowel health is a lot more than IBD. There's also cancer risk, and having a low fiber diet obviously has got other risks to it. So yes, you would always need to take fiber in. The only
Mm.
thing is, if you're having an active flare and you're having active diarrhea, then having a very high fiber intake might not be the best thing to do. So again, it's usually individual balance, trial and error. But in general, you should comply with when you're not having flares or actively ill, is you should comply with just a healthy, balanced diet. And there is
Diet.
a lot more other things that can happen for which you still need to take your fibers in.
Okay. Are there any medications which, for example, you take for other things which could predispose to IBD or increase your risk that people need to watch out for? No.
Yeah. No.
Okay. Right. The other question is, how did people manage these conditions in the past before modern treatments like stoma bags existed? That's the question itself.
The answer would be badly because that's why the life expectancy was lower back in the day. This was a condition that used to kill a lot more people. People would end up coming in with perforations and fistulas and malnutrition and all kinds of issues, eventually develop cancers without having been screened. So yes, it used to be a lot less managed and a much more badly managed condition. Nowadays, with modern medicine and screening, the life expectancy gap is closing. Cancers get picked up early and they develop less. And patients have got a lot more medical options to trial and error their medical management to get some medical control and let them have as much as possible reduced symptoms and being able to live a full life.
Thank you. Thank you. Now, the other question is, does having IBD, Crohn's or colitis, affect life expectancy? I think you've touched on this earlier on, but since the question has been asked, is there anything that you could say in addition to what you've said before?
No, I can just reiterate that that gap is now closing, and that's because of the better treatment, screening, and everything else that modern medicine has brought. So while obviously the quality of life might be affected, the length of life is tending to now get closer to
Narrowing of the gap.
population.
Okay. Now, question of my own. How do you firmly differentiate between inflammatory bowel disease and irritable bowel syndrome?
They're two very different conditions. So irritable bowel syndrome should really be what we call a diagnosis per exclusion. So you should only get labeled IBS if all other things are ruled out. And it's kind of it's not really a condition, it's more a package of symptoms that we're not able to explain can't put a label on, but also have excluded all the scary things and all the things that need to be treated. While inflammatory bowel disease is a true condition that
Proper
you can
diagnosis.
biopsy, diagnose, and say this is that. The problem is that a lot of patients who end up having IBD, so inflammatory bowel disease, have been labeled IBS in the past and under investigated. And I think
That's
that's a
what
very
we-
vulnerable group where improvement can be made.
Yes. Okay, right. Are there any links between stress and depression, for example, and IBD? So if you're stressed and depressed, chronic stress, chronic depression, are you more liable to have IBD?
Not as far as the literature suggests, as I'm aware. The other way around, obviously, having a chronic condition predisposes you to more anxiety and psychological symptoms, but not the other way around. I don't know if Dr. Titcombe has got any available literature. As far as I know, it's not related.
No, yeah, I'd agree with you. As far as we know that for some there is definitely kind of a gut-brain connection. So for people with Crohn's or colitis, some people do find that stress can make their flares worse, can make their symptoms worse. But no, as Dr. Marwa says, the other way around. To my knowledge, no evidence to suggest that.
Okay, so a few more questions coming in. I think this one has been looked at. What strategies can individuals with Crohn's or colitis use to manage stress and its impact on their condition? Also, would food intolerance tests help? Some people don't know they are intolerant to dairy or eggs.
So that's a separate issue. So if someone is coming in with unexplained bowel symptoms, etc., then depending on the set of symptoms, obviously it's a clinician's decision to investigate certain things. So yeah, if you've got IBS type symptoms, everything has been ruled out. Yes, then in some cases, in testing intolerances might be worthwhile. But that's a separate question from your
Okay. Yeah.
IBD. If you've got symptoms that fit with IBD, obviously that needs to be investigated first.
I just have a duty to put the questions forth
And
as
no, and it's also good to ask. I think it's important that people ask these questions.
my 12-year-old child is having symptoms, and the doctor was very reluctant to refer to a specialist, as according to them, these exams do not tend to find anything on young people, and the risks outweigh the benefits. Is that true? I tend to believe that this has to do with the long wait list on NHS. I suppose some reassurance needed here. I'm not sure.
I would find it hard to comment without knowing what the symptoms of the child are, what the balance here has been made. A blanket statement of these investigations not working in young people is not true, as in these investigations can be done on young people and teenagers can still be diagnosed as children with IBD. So that's still a possibility. In general, there could also be lots of other conditions that could give similar groups of symptoms. If you feel that you're not getting what you need, then it's always important to seek a second opinion, and to look for resources that can guide you on how to seek a second opinion and advocate for you and your child if you feel you're not getting anywhere. That's separate from the IBD.
I like very much the clarity of your answers. Thank you very much. Now, is IBD passed down genetically? That's the question. And my addition to this is that if it is, then how can the immune system be modified or controlled to reduce the incidence of IBD?
So it is not fully a genetic pattern. So even though there is some pattern to it, and people who've got family members are at increased risk, it doesn't necessarily mean that, oh, if your mom and dad don't have IBD, then you can never get it. That's not true. So it's a combination of environment and genetics, Along with sometimes there are some theories that certain events trigger the development of your IBD. Like I said, it's still a developing field, and a lot of information or theories are still under investigation or not really understood the mechanisms yet. So that's the part about the genetics. It's not purely genetics. Sorry, remind me again of what the second part of the question
Yes.
was.
Are there any known ways of modifying the immune system to reduce the incidence of IBD?
So not to reduce the incidence of IBD, but to control the disease, the
Yes.
mainstay of the disease control is by medication that affects the immune system. So immunomodulators and immunosuppressants.
Mm-hmm. I was thinking more of, say, prophylaxis, but I suppose that's not an issue at the moment.
No, not the science hasn't gotten there. No.
Okay. Right. I think we have come to the end of our questions. This has been a very, very good session. The time has been utilized almost to the minute. And I want to thank you very, very much for, well, all three presenters very, very much for the clarity of your presentations. At this stage, I will pass on to Christiana, and Christiana will close our session for us. Thank you so very much, and we're very grateful for your presence this morning. Christiana.
Thank you. Thank you so much, Dr. Michael, and thank you as well to Dr. Sophie and Dr. Marwa. I think it's been a great session. I'll just quickly go through our closing slides. I hope everybody can see my screen. I think it's just coming up. Yeah. So thank you once again, everyone, for joining. So our health hour will return next week, and the topic is stroke awareness. So same time, 11 a.m. to 12 p.m. So if you want to register for this session, you can email info@cahn.org.uk, or you can scan the QR code above. We also, I hope you can see my screen. 1 second. Okay. Okay, there we go. We also have so our Black Healthcare Awards nomination. The deadline is tomorrow, midnight specifically. So if you have not yet nominated anyone, please do before the deadline is up. So tomorrow is the deadline. So if you have like to nominate anyone, please do give someone a lifetime of recognition. They can scan the QR code here if you like to nominate someone, or I believe there's also a link. So probably the link will be shared soon on the chat. So based on what we discussed today, so CAHN and Crohn's and Colitis UK, I've worked to create information resources designed for Black people living with the disease. So if you want to find out more, you can do so by scanning the QR code here on this page, on this slide. Africa Day 2025 is on the 22nd of May. So the theme is Accelerating Business Growth and Technology, and it's going to be at the University of Greater Manchester. So it's going to take place, the time is taking place between 10 to 3 p.m. So if you'd like to register, which is a free entry, you can do so via the QR code. If you'd like more information, you can also email or call the contact below. The Family and Advocacy Empowerment webinar will be taking place on the 15th of May. And the title is going to be based on workplace discrimination specifically. So if you would like to register, like to attend, please do contact Family Advocacy at CAHN.org.uk, or you can scan the QR code. So it's going to be online at 6 p.m. on the 15th of May. We also have a Caribbean and African Cultural Wellbeing Hub, and it's at the Sacred Heart in Gorton. So if you like support, anyone that support for any sensitive support for pregnant individuals, for their families, their babies, please, you are more than welcome to join. And if you'd like more information, you can email pimh@cahn.org.uk, or you can call our helpline on the slide showing now. We also have a online talk specifically for young people. So it's titled TikTok to Table Talk, Understanding Gen Zs. So this will be taking place on Monday, the 21st, 11 a.m. It's open to all. We have the link here on the slide. If you'd like to register and to attend, please, you're more than welcome. And if you'd like more information, you can contact Daniel at healthandwellbeing@CAHN.org.uk, or you can also scan the QR code as well on the slide. We also have on the 24th of April, we have a Zoom session titled Genetics, What Matters to Our Community. Everyone is welcome as well if you'd like to participate. It's going to be focused on how genomics impacts prevention, treatment, and personalized health. So for more information, contact hello@inspireblackhealth.london, or you can also scan the QR code on the slide here. So thank you once again, everyone, for joining us. We hope to see you next week for another great session. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite